see what we can plow through today. So we ended last time looking at the different portions of the brain, major lobes of it, major structures you need to be aware of. And so then we need to supply that brain with blood. So what are the different arteries supplying the brain? So the four major arteries coming up the neck into the cranial cavity supplying the brain are what? Yep, common carotids and the vertebrals. Okay, and then the common carotids split into the external and internal. The internal are the ones that are going to supply the brain itself. The external go out and supply the face and superficial structures. Okay. The right vertebral, the right and left vertebral arteries, where do they run up? What's their pathway up the neck? Yeah. Yep, the foramen transversarium, through those holes in the transverse processes of the cervical vertebrae. They then connect in the basilar artery. And so we have the basilar artery and the left and right internal carotid arteries coming in to this circle here, the cerebral arterial circle. Or this is also called the circle of Willis. Willis, okay? That's an older name. So we have this circle, and then from that circle, we have branching off of it the cerebral arteries. So we have the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral arteries. Okay. So if we look at the underside of the brain, we see how this is laid out on it. So we have the vertebral arteries coming up here and kind of joining in together to form the basilar artery. And that then continuing onward into the arterial circle there. Excuse me. Remember when we were studying spinal cord in the back, we had the anterior and posterior spinal arteries. So here's where they're branching off of the vertebral arteries and going down the midline of the spinal cord there. Then we also have branches, lots of little branches. You don't have to know these branches by name, but just know that off of the basilar is where we have all these branches that feed the cerebellum. So all the cerebellar branches there. Okay. So then also we see here these cut vessels. These are the internal carotid arteries. Coming into that circle there. And then we have our anterior cerebral coming out anteriorly, as the name implies. The middle cerebral here is actually coming in out underneath the temporal lobe. So here's the temporal lobe right here. It's coming out underneath it and will emerge on the surface of the cerebrum between the temporal lobe and the parietal lobe. And then finally our posterior cerebral here branching off the posterior portion. Okay. Now if we take that and then map out where those major cerebral arteries go, there's several regions that each one covers. So on this one you can see the kind of blue-purple color is the middle cerebral artery here. And so it's going to cover a large portion of the frontal lobe here, a lot of the parietal lobe, and quite a lot of the temporal lobe, and these lateral surfaces. So the lateral surfaces. Okay. Now if we take and split the two hemispheres apart from each other, so we sever that corpus callosum, we can see the majority of the area that's supplied by the anterior and posterior cerebral arteries. So green would be anterior cerebral, getting that medial wall of the cerebral hemisphere in the frontal and parietal lobes, and it does, if you remember from the previous picture, comes over and gets the edges here as well. All right, the same for the posterior, getting the edges around the edges of the cerebral hemisphere. And so then we have posterior here coming and catching the temporal and occipital lobes, the medial aspects of those lobes. Mm-hmm. All right, so like every artery in the body, the arteries leading to the brain can become stenosed and narrowed, and then that would cause reduced blood supply to the brain and potentially cause an ischemia. So this is just an image illustrating what would be normal in the branches, that carotid sinus where the external, internal carotid arteries branch off of the common carotid, and then just an image of a stenosed artery. Okay. Another problem can be aneurysms, and apparently those arteries in that cerebral arterial circle actually quite commonly have aneurysms that people live with and aren't ever really aware of until, of course, they rupture, and then you've got a problem, because then that can also lead to loss of blood flow and ischemia. So they can be, the large aneurysms is shown here with these 3D rendered CT scans, and remember, it's just a ballooning of the vessel because of weakened connective tissue in the wall. Or there's also what they call Berry aneurysms here, and these are smaller little bleb-like aneurysms, kind of like those small diverticula off the gut when we were talking about the colon. And those can often come up on these vessels in and around the cerebral arterial circle. And again, unless they rupture, they're not a problem, but if they rupture, then we've got hemorrhaging in the brain. All right, so speaking of hemorrhages, so depending on where the hemorrhage is, we've got different names for it, obviously, because that's what we do in anatomy. We name everything. So then, if we look at fractures to the skull bone itself, typically we're going to have the bleeding between the periosteum and the dural meninges. So this would be our extradural hematoma. Sometimes the veins leading into these dorsal venous sinuses can get ruptured and lead to a subdural hematoma. So these subdural hematoma. And then finally, in the last space we have within the cranial cavity, we have the subarachnoid space, and that can have hemorrhages in there, typically through a ruptured aneurysm, and that would be then able to not only bleed out wherever the rupture is, but it will very often travel through the subarachnoid space because it's a continuous space. And so there tends to be pooling in areas where the arachnoid mater and the pia mater are more separated from each other, so there's these spaces between it. And so you have tendency of blood to pool in those basilar sinuses there. Okay. So just some images. These are, I believe, CT scans showing each of these types of cranial hemorrhages. So we have the extradural hematoma, which is very typically this kind of lens shape. Remember, the bleed is coming from outside the dura, and the dura is very tightly adhered to the periosteum, so only typically a small portion bubbles out. Okay. And you can see here that there's a pressure on the brain tissue causing a shift in that falx cerebri, that dural reflection in there. So pushing that away, indicating that pressure that's on the nervous tissue. For a subdural hematoma, so this is between the dura mater and the arachnoid mater, they tend to be a little bit more spread out, and the extent obviously is going to be relative to the volume of blood that hemorrhaged, and again, causing deformation of the brain, compressing the brain, and by compressing it, causing neurological symptoms. And then here you can see on this side a more kind of normal shape for the lateral ventricles, and on this side the lateral ventricle has been actually pushed all the way over here next to the other ventricle. And then finally we have our subarachnoid basal cisterns here. So typically you would see a darker structure in these cisterns. So CSF is going to be typically a darker color, but because there's blood accumulated, we see the lighter color there instead. So this is blood accumulating in those cisterns at the base of the brain. Any questions about anything?
So you said one more time the subarachnoid is below. Is it in between the pia mater and the subarachnoid?
Yeah, so the arachnoid mater and the pia mater, that space between them is the subarachnoid space, and so a ruptured aneurysm within that sphere would be what causes pooling of blood in this region. Because remember, the subarachnoid space is continuous throughout the whole surface of the brain. Any other questions? Okay. All right, so then we also obviously can have a hemorrhage on the outside of the skull. And this often happens during childbirth. When it does happen, is the pressures on the skull, and anything that would rupture a vessel in there and fill in the layers between the skull and the skin. So there's a layer of loose connective tissue that blood can bleed into fairly readily. All right. Cranial nerves. So there's a few general characteristics I want to point out to you. You do need to know the cranial nerves by their names, because they're going to come into play when we're talking about innervation of facial structures. We've already talked about it with like the trapezius, and then also some neck structures that are going to be innervated by these, so might as well get them in your head now. There's 12 of them, and they're all paired. And with the exception of the olfactory nerve and the optic nerve, they all emerge from the brain stem. Okay, so all of these emerge from the brain stem. Pardon? Okay. The optic nerve and the olfactory nerve go directly to their sensory cortices. Okay. All right, so then there is, obviously each one has a function. I like this figure because it shows which one has sensory and which one has motor fibers. So you need to know whether the cranial nerve is sensory or motor. What is it innervating? And then there's a table in your book. In my version, it is on page 855. That looks at what you would see if there's a lesion in that nerve. So if that nerve is disrupted, what are the deficits you would see? So, for example, a lesion to the hypoglossal nerve, what would we expect to see as symptoms? Yeah, so you have problems moving the tongue. What kinds of behaviors would be impeded? Speech. Tongue is very important. Speech, chewing, swallowing, all those types of things would have some problems. Okay, so that's just an example. Remember for the vestibulocochlear nerve here that it splits into two nerves, the vestibular and the cochlear nerve. So the cochlear nerve is responsible for sensory information coming from the ear, so hearing. And then vestibular would be involved in balance, because remember the vestibular system controls our body's ability to orient in 3D space. Okay. The rest of them have their functions listed out fairly well, so I don't think there's a reason for me to go over them in detail in lecture. Just know them, and then know from the table on page 855 what happens when something goes wrong, when there's a lesion in that. Okay. All right, so the muscles of the face, most of the muscles of the face, excluding the masseter and the temporalis muscles, are grouped as facial expression muscles. So these are obviously going to control the facial expression. As a whole, they are innervated by the facial nerve. So that'll make it easy. Innervation's simple, facial nerve. Okay. Divided up into several subgroups based on what structures they move. So we'll just kind of cruise through those subgroups. So here's the orbital group. Obviously, they are associated with the eye and are involved in moving the eyelid and the eyebrow. Okay. So here, this muscle would be important in moving the eyebrow. These would be opening and closing the eyelid. Something that the face uses, especially around the eye and the mouth, are these circular muscles here. So just to note these circular muscles, so constricting them would be narrowing the aperture between them, thereby closing the eyelid. Okay. We have the nasal group. Obviously are going to be involved in moving the nose. We have some that are coming down superiorly, and also some coming up inferiorly, as well as the ones that are actually located on the nose themselves. As far as names, be aware of the names and know which group they belong to. I won't ask you to know the specific function of each one, because they'll work together, knowing that one of those is going to lift the corner of your mouth in this direction is not going to help you as much as knowing here's the muscles, here's kind of the group, and then generally, okay, if that group of muscles is paralyzed, or partial group of that part of the group of those muscles is paralyzed, you're going to have what kind of symptoms. So paralysis of those facial muscles, we're going to cause drooping, right? So inability to contract those muscles. So paralysis of the orbital group would potentially cause drooping of the eyelid, eyebrow area, etc. Okay. All right. Here is the oral group. This is a rather large group, but it allows us. This is the amazing thing. All these little muscles allows us to generate all the facial expressions using our mouth. So smiling, frowning, the fact that we can speak clearly is all contributed to by this group of muscles. And again, we see again around circular muscle moving around the muscles around the the oral cavity opening, so that clenching those down can shrink the size of the mouth opening. So then these ones here obviously would be involved in pulling the corners of the mouth down, whereas those here would be pulling the mouth, or the corners of the mouth up. All right. Okay, here's just a side view of the superficial muscles of the oral group are removed, and we have the deep muscle, the buccinator muscle, as the deep layer there. And then finally, there's a couple of other groups that don't have a name really, but these ones are associated with the ear. We don't really think of moving our external ear a lot, but we can. My uncle has somehow the amazing ability to wiggle his ears consciously. It's rather weird, but it's kind of fun. It is. He tells us that he's pinning his ears back like a horse, so he can actually flatten them against his head. It's really quite hilarious. Funny man. Anyway, so that can be a goal to increase your voluntary control of your position. There you go.
Homework assignment.
There you go.
Learn your ears.
Extra credit?
I know. Everyone's like,
Okay.
that face, like, and what? It's subtle though.
Yeah.
Hold on. Just stretch.
Okay. Oh gosh. Okay, so muscles of facial expression.
Sorry.
So why are we bringing in the conversation about the parotids and the salivary gland when we're talking about facial expression muscles? Well, we've got the facial nerve here that's actually branches and runs through the parotid salivary gland. So here, kind of, if you look at a cross section, if you cut through here and look down, you have the muscle and the mandible here, the two muscles, the masseter and the medial pterygoid muscle, and then the salivary gland sitting right on top of that. That facial nerve runs right through it, and as illustrated here, has lots of small branches throughout it. Okay. Why does this matter? Well, the parotid gland is, any salivary gland can have a tumor grow in it, and 80% of all salivary glands tumors are in the parotid gland.
Can you repeat that?
So 80% of all salivary gland tumors are in the parotid gland. Okay. And so to resect that tumor, obviously they're going to remove at least part of or all of the parotid salivary gland. But it's a pretty tricky dissection because of all these branches in the facial nerve, in the gland. So they're just all throughout it. If you're not careful, obviously you can sever or lesion one of those facial nerves, and now you've got paralysis of some of those facial muscles, and then that person's stuck with a drooping mouth or drooping eyelid or whatever because of that. So it's a very difficult dissection to do. So here's just a quick image. Here's a normal parotid gland on this side. You can see it kind of sitting over the top of the structure. So here's the mandible here, the masseter muscle, and the parotid gland sitting kind of right next to it. And then here you can see a increased density mass, so a brighter mass in the left parotid gland there. All right, I think that's enough for today. Any questions? Well, have a good weekend.
No.
He accidentally grabbed like 2 packets and was like, oh my gosh. It's probably my hair.
It made her nervous. It did make me
Class next Friday, are we?
No, I don't think so. I don't think we do. But I'll make sure of that. My chance to look at all of the